Hello and welcome to Foundation Training with Klira. Today we are going to discuss what is Klira, the disease states that we treat with Klira, how it works, and the bespoke formulations that we have. We're going to look at the dosage for tretinoin and how it escalates, the treatment protocols, and how to choose the right formula for your patients. We'll talk about the patient's journey and the guidance overview of Klira and touch base on the pricing. Klira is a prescription skincare platform that specializes in bespoke compounded formulations, meaning each cream is made to order for an individual patient, combining clinically proven medications in a base that suits their skin type and condition. Every formula is tailored, which is what makes it genuinely different from anything you'd find in a pharmacy. As Klira prescribers, you have access to these formulations. You choose the actives and the base, and Klira's compounding pharmacy does the rest. Klira Pro is the professional arm of Klira, designed for clinicians who want to offer patients a structured, evidence-based prescription skincare pathway. The focus is on first-line topical treatments for conditions that present regularly in clinical practice. Each patient starts on a simple nightly 6-month plan, 2 pumps of combined formula. The simplicity is intentional. Complicated routines lead to poor adherence, and poor adherence leads to poor outcomes. Depending on the formulations, the strengths of the ingredients increase automatically on a monthly basis, removing the need for follow-up, dose adjustments, and appointments. It is also worth noting the cost differential for patients. Through a prescriber, patients pay £59 per month. Going through directly with Klira website, that rises to £75 a month. Patients receive clinical oversight and a personalized prescription journey at a lower cost than self-referring online. Each Klira formulation is a bespoke compounded preparation matched to the clinical needs of 7 common facial skin conditions: perioral dermatitis, acne, adult female acne, rosacea across all subtypes, hyperpigmentation, photoaging, glow and radiance, and DSAP. DSAP is worth highlighting separately, as this is a formulation that is off-license and restricted for dermatologist prescribers only. This is a treatment for disseminated superficial actinic porokeratosis, and it's not for profit. What Klira has done is to batch order and produce this cream once a month to make it more affordable for patients. It works out to be £65 for 100 mils every month, and you can cancel at any time. But what we want to focus on is the base selection, which is what Klira is known for. It's a clinical decision in itself. The light base is suited for more sebaceous, oilier type of skin, such as acne-prone skin. The rich base adds collagen, peptides, and cholesterol, making it more appropriate for a photoaged or hyperpigmented skin needing additional barrier support. The ultra-sensitive base, ceramides and squalene, is formulated for compromised skin barrier conditions such as rosacea and perioral dermatitis. This formulation has a serum-like texture, and it's free from preservatives such as phenoxyethanol, a recognized trigger for flares in sensitive skin conditions. This is particularly relevant where patients have been failing to improve despite appropriate actives. The excipient profile for their current product may be perpetuating the current inflammatory cycle. The default escalation progresses every 2 months, starting at 0.01%, moving through 0.025 and 0.04%, reaching the maximum of 0.05% at month 7. Throughout the entire journey, the patient simply applies 2 pumps nightly. The routine never changes, only the concentration within the formulation does. The 6-month plan is intentional. It is not about reaching maximum dose quickly, it's about building tolerance progressively. That said, there is clinical flexibility for these patients. For acne patients where faster response is appropriate, you can start at a higher concentration from the outset. At 6 months, prescribers reapprove before the patient continues, providing a natural clinical review point. Patients also have a direct derm team access for any concerns arising between reviews. The most important conversation to have at the point of prescribing is around realistic expectations. Month 0 to 3 is an adjustment phase. Purging, dryness, irritation is expected, and patients need to be counseled on this upfront to prevent unnecessary discontinuation. Around 1.5 months, patients typically notice improved brightness and texture as keratinocytes turnover increases. From month 5 onwards, fibroblast activations begins driving collagen and hyaluronic acid production. with improvements of texture and fine lines. By month 9 to 12, deeper lines, pigmentation, and skin firmness continues to improve. Results are cumulative and adherence dependent. Patients who discontinue during the initial phase will not reach the outcome seen in the optimization phase. The important thing is to understand that each formulation is different. These ingredients are selected specifically to work synergistically with the active medications for each individual skin condition. Essentially, these are the key ingredients that support and protect the skin barrier while the actives do their work. Shea butter and aloe focus on hydration and reducing transepidermal water loss. Caprylic triglycerides and squalene facilitate delivery of the active ingredient while maintaining tolerability. And collagen peptides support moisture retention within the stratum corneum. A conventional prescription gives you the active ingredients in a basic vehicle. What Klira delivers is essentially skincare and medication combined into a single formulation. The base is doing much clinical work as the active itself. That's not something you get from stock standard tretinoin or azelaic acid cream off a pharmacy shelf. Now looking at disease states that we treat. Chronic facial skin conditions such as acne, rosacea, photodamage, and melasma are incredibly prevalent and carry a significant impact on the quality of life. These aren't cosmetic concerns, they're persistent clinical conditions that affect patients' confidence, mental health, and day-to-day well-being. Looking at the UK data, 85% of adolescents are affected by acne vulgaris at some point. But the key thing here is that acne doesn't stop at adolescence. Around 45% of women in their 20s, 26% in their 30s, and 12% in their 40s are still reporting clinical acne. Adult female acne is significantly under-recognized and underrated. And these are exactly the patients who end up cycling through over-the-counter products without ever getting a structured clinical intervention. What that means in practice is that there is a large patient population who need access to prescription strength treatment, but either don't know where to go or find the traditional prescribing route inaccessible. That's where Klira becomes really relevant. The platform is designed to make evidence-based prescription skincare more accessible. 2 pumps a night, multiple actives working in combination with a base optimized for tolerance and efficacy. It removes the complexity for the patients while maintaining the clinical rigor that a prescription pathway requires. Acne vulgaris is a chronic inflammatory condition of the pilosebaceous unit, essentially the hair follicle and its associated sebaceous gland. It predominantly affects areas with highest density of sebaceous glands, which is why we see this most commonly on the face, upper chest, and back. In terms of pathogenesis, there are 4 key drivers. Androgen hormones stimulate the sebaceous gland to overproduce sebum. That excess sebum, combined with abnormal keratinocyte shedding, leads to follicular plugging. Within those clogged follicles, Cutibacterium acnes proliferate, and it's the immune response to that bacterial proliferation that drives the inflammatory lesions. So what you see clinically is papules, pustules, nodules, and cysts. And the key thing is, because acne is multifactorial, effective treatment needs to address more than one of those pathways simultaneously. That's precisely why a combination formulation approach targeting sebum, bacteria colonization, and inflammation together is clinically more effective than a single active in isolation. The 2 key topical treatments that sit within NICE guidance for acne and that Klira concentrates on are topical retinoids and azelaic acid. Tretinoin is the topical retinoids, being the one used within Klira, working by promoting cell turnover, reducing comedogenic, and exerting anti-inflammatory effects. They are effective for both inflammatory and non-inflammatory lesions, applied once daily in the evening. The initial side effects of irritation, dryness, and peeling are well documented, which again brings us back to why the escalation protocol and the base selection matter so much for tolerability. Azelaic acid complements this really well. It has antimicrobial, anti-inflammatory, and chemolytic properties and is particularly effective for mild to moderate inflammatory acne and post-inflammatory hyperpigmentation. It's generally well tolerated with minimal side effects. What the evidence also supports is the combination approach. Clinical studies have shown that aloe vera combined with tretinoin outperforms tretinoin alone in reducing acne lesions, with patients reporting fewer side effects and better tolerability. In vitro studies further indicate that aloe vera enhances the penetration of retinoids, potentially increasing their therapeutic effect while reducing irritation. Adult female acne affects women aged 25 and older and is often chronic in nature. What makes it distinct from adolescent acne is that hormonal fluctuations play a much more significant role. Menstrual cycles, pregnancy, menopause, and conditions like PCOS all drive increased androgen activity, which in turn increases sebum production and perpetuates the acne cycle. Discontinuation of the oral contraceptive pill is a really common trigger for acne flares in adult women, as the hormonal regulation it provides is suddenly removed. This is a presentation clinicians see regularly, and it's worth having a structured prescribing pathway ready for those patients. The pathogenesis follows the same 4 drivers: excess sebum, follicular hyperkeratinization, Q10 bacterium acnes proliferation, and the subsequent inflammatory response. What the diagram on this slide illustrates well is how many external factors feed into that cycle. Stress, diet, smoking, medication, and endocrine conditions all contribute. That is why adult female acne can be so persistent, and why topical prescription pathway addressing multiple mechanisms simultaneously is often the most effective approach. The topical actives used for adult female acne are essentially the same as for acne vulgaris generally. Tretinoin and azelaic acid remain the first-line prescription topicals, working through the same mechanisms of promoting cell turnover, reducing comedogenesis, and addressing inflammation. The key difference with adult female acne is that the underlying hormonal drivers often need to be considered alongside the topical prescription. Topical treatment alone may not be sufficient if there is a significant hormonal component, particularly in patients with PCOS, premenopausal acne, or those who have recently discontinued oral contraceptive pills. In those cases, second-line or adjunctive systemic treatments become relevant. Oral options worth being aware of include combined oral contraceptives, which can regulate androgen-driven sebum production, spironolactone for PCOS, which is increasingly used off-license in the UK as an anti-androgen for hormonal acne in women, and in some cases, low doses of oral antibiotics used short-term to manage the inflammatory burden while topical treatments establish. For patients where there is a suspected endocrine component such as PCOS or insulin resistance, onward referral to endocrinology or gynecology may be appropriate alongside topical prescribing pathways. The important clinical message here is that Klira sits within the topical first-line pathway, and for many adult female acne patients, it will deliver meaningful results. But having an awareness of when a hormonal or systemic conversation is needed alongside it makes for a more complete clinical approach. This is a really good example of what adult female acne typically looks like in a clinical practice. Looking at the before image, there are a few things worth pointing out. There is a small amount of excess facial hair, which is a subtle but relevant clinical sign, worth noting as it may indicate an underlying androgen excess. There is visible perifollicular redness, pustules including that characteristic small yellow pustules centrally, and comedonal acne around the nose, chin, and sides of the cheek. It is worth noting that the nose itself tends to be spared from inflammatory red lesions, which is a pattern clinicians often see with adult female acne. The formulation prescribed here is a light base with aloe and hyaluronic acid, appropriate for acne-prone skin, combined with tretinoin escalating from 0.01% to 0.05% over the 6-month plan, alongside azelaic acid 20%. The after image reflects what consistent use of combination can achieve. In terms of consultation, beyond the clinical assessment, there are some really important questions to ask. Oral contraceptive pill history is essential. Whether the patient is currently on it, has recently stopped, or has never used it at all changes the clinical picture. Current skincare routine matters because occlusive agents in particular can perpetuate acne and undermine the prescription. And a full medication review is important as some oral medications can be acnegenic. This is a good prompt for clinicians to think holistically rather than prescribing topically in isolation. Now let's use the platform to prescribe for an acne diagnosis. You want to choose your patient and add a prescription. You always want to make sure you got the patient's name right and the clinic, and you always want to click on every 6 months. This is where the prescription expires after 6 months, and also gives you an opportunity to check in with your patient again and either re-prescribe or update their prescription or continue with their formulation as expected. Now, prescribing for acne, we've got these little drop downs that make it easier for you. And basically, we know that tretinoin is going to be acting into clearing the sebaceous units from getting blocked, and azelaic acid is going to help with that inflammation. So 20% is usually the percentage or the dose for treatment of acne, and then you want to choose either the light base or rich base for your patient. And that will depend on your patient's skin. So if I could say, for example, click this, you can start from the very beginning, 0.01, and this is how you escalate, or the default escalation of the dose is. So you're on the same dose for 2 months before getting bumped up. If we were to escalate as usual, this is what it would look like. 2 months on each dose before moving up. And you see at month 6, they're only at 0.04% tret. So after you do this and you're happy, you want to create prescription. If you have a patient, for example, that has been using other brands of tretinoin or prescription grade actives, say for example 0.025 tretinoin of a different brand 3 times a week, you may want to look at dropping their dose and starting them at the second month of 0.01%. And if you go preview prescription, they're only doing 1 month of 0.01% because I've started them on the second month over there. And why do I do this? Because we are adding another active, azelaic acid 20%, to their usual routine. And also, because Klira is designed to be used every night, so the dose frequency is nightly. If they were using tretinoin 0.025 3 times a week, they may not tolerate that dose using it nightly. So that's why I've dropped it to 1 month of that, including azelaic acid. So what you're looking at here is subgroup 1 rosacea, what we refer to as sebaceous rosacea or papulopustular rosacea. And if you look at the clinical picture, there is this really typical presentation. You've got diffuse erythema across the cheeks and nose, papules, pustular lesions, and this is what lands in your clinic regularly. Now, in terms of what's actually driving this, the pathophysiology isn't really fully understood, but there are 5 key contributors I want you to be aware of. Firstly, chronic inflammation causes sebaceous gland hypertrophy over time. That's what leads to the skin thickening and irregular texture you see in the more advanced cases. And in severe cases, phymatous change. Microbial factors are really important here. Demodex folliculorum mite overgrowth and Cutibacterium acnes both exacerbate the inflammation response. And that is directly relevant to how we formulate for this condition. The vascular component is what your patients tend to find more distressing. Persistent vessel dilation drives the chronic erythema and the telangiectasia, and that often is what brings them through the door. There are genetic predispositions, so it's always worth asking about family history during consultation. And finally, the immune system dysregulation. This perpetuates the inflammatory cycle, which is why rosacea tends to be chronic and relapsing rather than self-limiting. The key thing to take away from this is that because rosacea is multifactorial, a formulation that addresses both inflammatory and microbial components simultaneously is going to give your patients a much better clinical outcome than a single agent approach. Now that we've covered what's driving rosacea, let's look at what we're actually prescribing for it and why those choices make clinical sense. The 3 actives used within Klira rosacea formulations are topical retinoids, azelaic acid, and ivermectin 1%. And each one of these is targeting a different part of the pathophysiology of what we've just discussed. Tretinoin addresses the inflammatory and comedonal component, promoting cell turnover and reducing comedogenesis. Azelaic acid brings in the antimicrobial and anti-inflammatory properties and is particularly useful for the post-inflammatory erythema and pigmentation that rosacea patients often carry. And the ivermectin, it is an antiparasitic that directly targets Demodex mite overgrowth, which, as we discussed, is one of the key microbial drivers of inflammatory rosacea. It is applied once daily, and the evidence shows meaningful reduction in both inflammatory lesions and erythema. What that means in practice is that by combining all three, you're targeting the vascular, microbial, and inflammatory pathways simultaneously. And the evidence supports the combination approach, giving improved outcomes over a single agent alone as well. For rosacea, the Klira formulation uses the ultra-sensitive base, and we touched on this earlier that it's free from phenoxyethanol, known as a recognized trigger for rosacea. So removing that from the vehicle is a clinically important decision, not just a formulation preference. This is a great clinical example to walk through together. Looking at the before picture, you can see the hallmark features: significant diffuse erythema across the cheeks and nose, rough skin texture, red papules, and some pustular lesions. And importantly, notice the absence of comedones. That is the key differentiating feature from acne. Rosacea typically presents without comedones, which is one of the things that helps you distinguish between the two at consultation. The formulation prescribed here is the ultra-sensitive base with squalene and ceramides, and the actives are ivermectin 1%, tretinoin, escalating doses from 0.01% to 0.05% over the 6-month plan, and azelaic acid at 15%. The after image speaks for itself in terms of what that combination can achieve. In terms of your consultation, there is a few things I'd want you to ask every rosacea patient. Current skincare routine is really important, particularly whether they've been using any acne-related treatments, as these can significantly aggravate rosacea. Ask about stinging or burning, history of redness and flushing, and always ask about the eyes. Ocular rosacea is frequently missed, and it's worth screening for at every consultation. The key thing to emphasize to your patients alongside the Klira prescription is that skincare simplicity is non-negotiable. Everything in their routine needs to support the formulation, not compete with it. Moving on to subgroup 2, and this is where rosacea can sometimes get missed or misdiagnosed because it presents quite differently to subgroup 1. Rather than the thickened sebaceous skin and larger pustules that we looked at, this subgroup is characterized by dryness, flushing, smaller papules and pustules, stinging, and telangiectasia. Looking at the clinical image, you can see the diffuse erythema and the fine papular lesions. The skin looks more sensitive and reactive than subgroup 1. The pathophysiology shares some overlap but has some important distinctions. Vascular dysregulation is much more prominent here. Persistent vasodilation and increased vascular permeability drive the chronic erythema and flushing that these patients describe. And immune system dysregulation is again a big feature, as it is present in all rosacea subtypes. What makes this subgroup particularly challenging clinically is the barrier dysfunction. Compromised barrier dysfunction leads to increased transepidermal water loss, heightened sensitivity, and dryness. And that means any treatment you prescribe needs to actively support the barrier rather than further compromise it. Demodex and Q2 bacterium overgrowth also contribute to inflammatory picture here. The key clinical takeaway is that these patients need a formulation and a skincare routine that prioritizes barrier repair first and foremost. Anything harsh, fragrance, or stripping is going to make this presentation significantly worse before it gets better. The active ingredients across both rosacea subtypes include tretinoin and azelaic acid, as well as ivermectin. And you might be wondering why we're using the same actives for dry sensitive as well as for the sebaceous one. And the honest answer is that the actives remain clinically appropriate across both subtypes. But what helps with this is the base and starting concentration or sustaining concentrations. The ultra-sensitive base in the serum form without phenoxyethanol is going to do the heavy lifting for this subgroup mainly. It is specifically designed to support the barrier while the actives work, which is why tolerability is maintained even in very sensitive skin. Regarding ivermectin, and this is worth being transparent about with your patients, is that ivermectin's primary mechanism is antiparasitic, so it's targeting those Demodex mite overgrowth, which is actually more prevalent in papulopustular rosacea, and that's where the evidence is strongest for the use of it. But in erythematotelangiectatic rosacea, so this is kind of dry, and vascular reactivity are more dominant features rather than papules and pustules, ivermectin is less impactful as a standalone agent because it isn't directly addressing the vascular component. The erythema and telangiectasia in this subgroup 2 are better managed through vascular targeted treatments such as IPL alongside topical prescription pathways. So the key message here is that Klira's topical formulation addresses the inflammation and the kind of or the microbial components effectively across both subtypes, but for patients with predominantly vascular subgroup to rosacea. Setting realistic expectations around erythema and flushing is an important part of the prescribing conversation. So this patient was prescribed the same actives. You've got your ivermectin 1%, the tretinoin in increasing doses, and azelaic acid at 15% in the ultra-sensitive base. But clinically, you can see this picture, it presents very differently from papulopustular rosacea. You've got this kind of background erythema, these kind of papular textural changes on the face. And I guess when or during consultation, that kind of question about heightened sensitivity, dryness, irritation is quite important here. And if a patient asks you about the evidence for long-term use of ivermectin, here's how I would approach the conversation. The published evidence for topical ivermectin 1% is that it supports daily use for over a defined treatment period. It supports once daily use over a defined treatment period of 12 to 16 weeks for papulopustular rosacea. The standalone license for the product Cilantra, which is your UK formulary ivermectin 1%, is prescribed on that basis, episodically with reassessment before continuation. However, with Klira formulation, ivermectin is used continuously as part of the combined preparation over the 6-month plan, which often differ from the license indication. The clinical rationale for this is that the continuous Demodex suppression throughout the treatment period supports the overall outcome, so preventing the mite populations from recovering between courses while other actives are working alongside it. In terms of safety, the topical ivermectin profile is well established and there is currently no evidence of harm resistance associated with continuous topical use, which is an important distinction from oral antiparasitic agents where resistance is a recognized concern. The honest answer to give your patient is that the continuous use with combined formulation sits outside the conventional prescribing literature, but the safety profile supports it, and it is a considered clinical decision within the formulation design that the Klira clinical team can review their formulation on an individual basis. Going back to the platform to prescribe for rosacea, we have an easy drop down here that has one formulation for rosacea, no matter if it's papulopustular rosacea or the dry flushing type of rosacea, and you want to click on that. Now remember, I mentioned that sometimes these patients do struggle on having higher doses of tretinoin or even reaching the max dose of tretinoin, so sustaining them at a lower dose can be quite helpful to prevent further irritation. So again, starting at the dose at the very beginning, and you can either sustain them at 0.01%, especially, say for example, the dry flushing type of rosacea, they do take longer to increase their tretinoin dose. And I sometimes leave this with the patients and let them get back to me whether or not they're ready to increase their dose to the next dose of tretinoin at 0.025. And sometimes they might never increase, or sometimes they might tell you at month 4 or 5, I'm not getting very much irritation, I would like to increase the dose, and you can always go back and update their prescription. So click on prescription, or if you were to cap the dose at 0.025, you can see that automatically they will finish 2 months of 0.01% and the tretinoin increases to 0.025%. And you just click on create prescription. Melasma is an acquired hyperpigmentation disorder, and looking at this clinical picture, you can see exactly what we mean by that. Symmetrical brown to grey brown macules and patches predominantly across the cheeks, upper lips and forehead. It's one of those conditions that patients often present having tried multiple over-the-counter products without success, which makes it a really common and rewarding condition to treat through a structured prescription pathway. It predominantly affects women, particularly those with high Fitzpatrick skin types 3 to 5, and hormonal influence is a major driver. Pregnancy-related melasma happens. It is a classic presentation, but it's also commonly triggered or worsened by oral contraceptive pills and HRT. Always ask about hormonal history at consultation. UV exposure is the primary trigger, driving increased melanin production by melanocytes, which is why rigorous SPF use is absolute non-negotiable for these patients. Without it, you will not get the results regardless of how good your formulation is. The other contributing factors worth being aware of are genetic predispositions, inflammation driving melanogenesis, and skin barrier dysfunction. The The key clinical takeaway is that melasma is chronic, relapse-prone, particularly with ongoing UV or hormonal exposure, so patient education around maintenance and sun protection is important as the prescription itself, and also managing expectations. The Klira formulation for melasma combines the three actives, hydroquinone, tretinoin, and azelaic acid, and each one is targeting a different part of the melanogenesis pathway. Hydroquinone is the gold standard depigmenting agent. It works by competitively inhibiting tyrosinase, the key enzyme in melanin synthesis. The important prescribing consideration with hydroquinone is that the long-term continuous use should be avoided due to the risk of irritated dermatitis and exogenous ochronosis. This is why the Klira formulation includes an automatic swap at 3 months unless overridden. That's really the clinical important feature and worth highlighting. It's building the cycling protocol into the prescription so the clinician doesn't have to manage it manually. Also worth noting, hydroquinone should be avoided in patients with a known PPD tattoo allergy. Tretinoin enhances the efficacy of hydroquinone by promoting keratinocyte turnover, improving penetration of the other agents, and azelaic acid at 20% adds the further mechanism of inhibiting tyrosinase and also helps with the inflammation. So this is a good safety profile with mild side effects. The combination of all three targeting different points of the pigmentation pathway is what makes this formulation clinically more effective than any other single agent in isolation. This is a really clear example of melasma and the results that are achievable in the right formulation and strict photoprotection. These photos are only 3 months apart, so this is after finishing the hydroquinone and tretinoin at escalating doses. This patient will then go on to use tretinoin and azelaic acid at 20%. Further improving the pigmentations that's left. Now back at the platform to prescribe for melasma and pigmentation, you want to click on this drop down, and I tend to always choose the second choice for hydroquinone and tretinoin because I would like the tretinoin in increasing doses. So if you were to start at the very first dose and max at the top end of the dose, you can see that the tretinoin still increases over the 6 months, but the hydroquinone 4% is only for the first 3 months, and that gets replaced by azelaic acid 20% at month 4. If you have a patient that you are wanting to cycle back on to hydroquinone after, say for example, if they've used tretinoin at max dose 0.05% with 20% azelaic acid for at least 6 months after the first cycle, you can always cycle back by using the third dose. And you might wonder, why is the tretinoin at 0.025 instead of max dose 0.05? This is because we are using or concentrating hydroquinone 4% to be the tyrosinase inhibitor to help with lightening up the pigment, and tretinoin at 0.025% is sufficient to do so. If you increase to 0.05, this is what it would look like. So basically, your patients will cycle back on with a lower dose of tretinoin and the hydroquinone 4% and then build their way back up again. For photoaging, the Klira formulation centers on 2 key actives, tretinoin and azelaic acid, and it's worth understanding why these 2 actives work so well together for this indication. Tretinoin is the gold standard topical treatment for photoaged skin, and the evidence is based behind it is the strongest of any topical agent. It works by increasing collagen synthesis, accelerating cell turnover, and reducing one of the key drivers of collagen degradation. It overall improves skin texture and tone. Azelaic acid complements this through a different set of mechanisms. Antioxidant properties that counteract the oxidative stress driving photoaging, anti-inflammatory effects, keratolytic activity improving skin texture, and tyrosinase inhibition, addressing the hyperpigmentation component. Used at typically 15 to 20%, it contributes meaningfully to both the pigmentation and texture outcomes your patient is looking for. The base for the photo-aging formulation is nourishing and specifically chosen to support the skin barrier and reduce inflammation alongside the actives, which again reflects the principle of the skincare and medication working together rather than in isolation. This is a really striking before and after, and it's a great example of what photo-aging looks like in a fairer skin type. Looking at the before image, I want you to take note at the clinical features. You can see solar lentigines, those sunspots distributed across the face. There's solar elastosis on the cheek, so that's the wrinkling and loss of skin texture that comes with accumulative UV-induced collagen degradation. The skin has a general roughness and dullness to it, which reflects the slower cell turnover that comes with photo-aged skin. And then there's telangiectasia present too, which is a common finding alongside UV damage in this skin. The formulation here is the rich base combined with tretinoin in escalating doses and azelaic acid at 10%. It's worth noting that the azelaic acid at 10% rather than the 20% used in the melasma formulation. A lower concentration is appropriate for photo-aging, where the primary goals are texture, tone, and collagen support rather than active depigmentation. However, with advanced photo-aging and if hyperpigmentation is a concern, then choosing or using 15% or above is appropriate. Looking at the after image, the improvement in skin luminosity, texture, and the reduction in lentigines is clearly visible. The tretinoin is doing what it does best, accelerating cell turnover, stimulating collagen synthesis, and reducing MMP activity over time. So SPF remains essential for these patients both during and after treatment to protect the skin remodeling that's taking place and prevent further UV-driven damage, undoing the results. Looking at the platform to prescribe for photo-aging, you want to select the first drop-down, and tretinoin is going to be your main driver to treat photo-aging. That is why azelaic acid is only at 10%. So you do have the option of light base, rich base, as well as tretinoin on its own without the azelaic acid, as some patients do find the azelaic acid a little bit tingly on the skin and prefer without. And again, choosing your dose will really depend on your patient's history, starting and ending as from the very beginning. You can see that, again, same dose for every 2 months. Now, if they have marked hyperpigmentation and would like to help clear that a little bit more, you do have the option of going into view of all formulations and choosing a higher dose for azelaic acid, either 15 or 20%. And I usually always still tend to treat photo-aging with the rich base, so there is an option for that. So how does Klira work? You will select the formula based on your diagnosis. So what are we treating and what is your patient's skin concerns? And select the starting and ending doses over the 6-month period. So things that would affect this would be factors like previous treatment, if they've ever used any prescription grade actives, and also time factors. And then selecting the base depending on your patient's skin type. A light base for more sebaceous, acne-driven skin, ultra-sensitive base for patients with rosacea, peri, or dermatitis or sensitive skin, and then the rich base for patients with dry skin types where the skin barrier needs a little bit more support. We did a small study on the Klira cohort of patients, and what the graph is showing is a direct comparison between standard tretinoin cream and Klira Special in a clinical trial. We looked at side effect profiles across 5 parameters: scaling at the corner of the mouth, increased redness, skin flare, the need to stop due to discomfort, and new papules or dryness on the face. Across every single parameter, the Klira Special significantly outperforms the standard tretinoin cream. The key takeaway from that data is that the choice of base directly improves treatment compliance and reduces side effects. And that's not a marketing claim, that's clinical trial evidence. This is really important to communicate to your patients because compliance is everything with tretinoin. A patient who tolerates their formulation stays on it. A patient who doesn't stops. And we've already established what happens to outcomes when patients discontinue early. The right base for the right patient isn't a secondary consideration. It's a core part of the clinical prescription decision. So what does the patient journey look like? The physician completes and approves the prescriptions in the clinic, and then the patient will receive an email with a link to payment. With that link, they set up their Klira account and put in the payment details, and what they can see is the prescription and patient information leaflet that's available according to what their clinician has prescribed for them. And then Klira takes it from there. The bespoke formulation is made fresh and sent out to the patient directly. The patient will then receive onboarding emails, including assembly and application guide videos. And if there is any treatment queries that come via the patient to Klira, we then re-refer back to the physicians to review. This is important because these patients still belong to you as their clinician or their prescriber, and any changes to their prescription, any updates to their 6-month plan can be made solely by yourselves only. As subsequently, a refill cartridge is sent to the patients every month. Physicians reviews treatment and follow on prescription every 6 months at a minimum. So this slide covers the pricing structure, and I want to be transparent with you about how this works. From a patient's perspective, the Klira Special nightly treatment is £59 a month on a 6-month subscription plan. As mentioned earlier, that compares favourably to the £75 a month if they were to go directly through Klira Skin online. So coming through you as a prescriber is genuinely the more cost-effective route for your patient. In terms of what you receive as a prescribing clinic, Klira pays £80 per 6-month prescription, including repeat prescriptions. And I want to be clear about what this payment represents. It is the administrative fees to cover your in-clinic dermatology costs and consultation time involved in the prescribing process. This is not a prescribing incentive, and your clinical judgment around whether Klira is appropriate for your patient should always remain independent of any administrative arrangements. Currently, that £80 is paid out on the 3rd bottle of every 6-month plan rather than upfront, and I appreciate that isn't ideal from a cash flow point of view, but I want to be open with you that this payment structure is currently under review, and we are actively looking at how to make it more beneficial and more timely for you as a prescriber. As soon as this is confirmed, we will communicate it directly. All treatment plans run via the 6-month subscription model, which provides consistency for both you and your patient throughout the treatment journey. Having said this, if a patient really disagrees with the treatment plan and really does not want to continue with the subscription, we are able to cancel this. Klira is a subscription model because we want to allow patients to escalate their doses accordingly so that to increase tolerability, but to also allow for patients to use a product consistently for a period of time to see meaningful clinical outcomes. And again, this is the patient price for the Klira Body DSAP, and that's £65 a month for a 100ml bottle. This slide is really about protecting yourself as a prescriber, not putting barriers in your way. Most of you will already be registered prescribers. That foundation is there. What this is about is making sure that if dermatology isn't where you originally trained, you have the evidence to show that you've built that competence. And honestly, that's not a huge lift. We're not talking about a single mandated national qualification, because there isn't one. What regulators want to see is that you've taken a recognized course, engaged in CPD in this area, and ideally had some supervised practice you can point to. For nurses, that means your NMC portfolio reflects this. For pharmacists, independent prescribers, GPHC want to see that education and supervision. For doctors, it needs to be safe and evidence-based, which when you're working with Klira's formulation and our clinical guidance, it absolutely is. The good news is that Klira Pro itself counts towards building that evidence base. This training, the clinical resources we provide, the support structure around you are all things that you can document and refer to. So if you're new to prescribing in this space, you're not starting from scratch, you're starting here. I want to be straightforward with you on this one. CQC registration is not a condition of prescribing with Klira right now, and many of our existing prescribers and clinics are not registered with CQC, and they continue to work with us without any issue. We include this slide because we believe in transparency and in making sure you have full picture. Technically, under the CQC definition, prescribing for a medical condition, including skin condition, although low risk, can fall under a regulated activity. It's something that the industry is increasingly aware of, and the regulatory landscape around aesthetic and prescribing skincare is evolving. So rather than telling you this is something you must do immediately, we do encourage you to see it as something worth working towards. Getting CQC registered puts you in the strongest possible position, professionally, legally, and in terms of patient confidence. It's a mark of credibility that sets you apart. If it's something that you're considering, Klira recommends Tracy Jones at Inspire to Outstand. She works with clinics through the registration process and offers a discount to Klira partners, but there is no pressure. For now, we just want you to be aware so you can make the informed decisions about where your practice is heading. So this is the partner onboarding process. The prescriber registration happens and the initial training is where we are completing right now. To close, I want to walk you through what joining as Klira prescribing partner actually looks like in practice, because it's a straightforward process and there's genuine support built in from day one. Getting started begins with the prescriber registration. Your clinic profile is created and your prescriber details are verified against your professional register. That's a routine ID and registration check, and it's a quick one to complete. From there, you'll go into the initial training, which is exactly what you're doing right now. This is delivered in person or via video call, as standard with me, but also now I've recorded this for you at your convenience. And as I mentioned earlier in this training, this is CPD accredited, so it counts towards your professional development portfolio and your competency evidence in this space. Once you've onboarded, you'll receive a marketing pack tailored specifically to your clinic, covering both in-clinic and digital materials to support you in introducing Klira to your patient base. We can also support clinic events if you want to launch this through your patients or your wider network in a more structured way. And finally, as Klira Partner Clinic, you have the option to be listed in the Klira directory on the Klira Skin platform. So to summarize the benefits, you're gaining access to clinically robust, evidence-based prescription pathway, CPD accredited training, tailored marketing support, and a referral network, all within a clinic team behind you to support complex cases and patient queries as they arise. If you want to register for the latest updates with Klira, this is our Klira newsletters where you would receive news of upcoming trainings or any webinars or any events that we might be attending or be present at. You will also receive top tips of our formulations and what's happening next with Klira. So this is completing the foundation training with Klira. We have just finished going through the deck, and that is the foundation training. There is also a video of the Klira platform training that you can have access to, but we did dip in and out of the Klira platform to enable me to show you how to use the system throughout this training. But once you complete your first prescription, you will then receive the Klira Foundation certification, training certification, and it looks like this. So this will be towards your CPD and evidence for training. So if you need help with any first prescriptions, or if you need to complete anything or need some support clinically, this is my contact number. I can be reached via email or WhatsApp. Do bear in mind I do work with Klira only 2 days a week, but I will get to you at the soonest. And again, if you want to book one-on-one meetings with me, this is the QR code to do so. And it is a 30-minute session where if you have any cases that you would like to go through, some pictures of your clients that you might want to discuss, this is the QR code to arrange that time. And just for an important contact number, I am in charge of your education and training or anything like related to clinical needs. And then we have Anna for any technical issues, login support, marketing material requests, and anything regarding your admin fees. Alternatively, if you can't reach any of us, there is the Derm team customer service email at the bottom there. So this is the foundation training that we've completed. The Klira platform training, which is a second video where I'll run through the platform and how to use it to prescribe for your patients and how to click through choosing the right prescription. And then once you complete your first prescription, you will receive the Klira foundation training certification. And that concludes your foundation training with Klira. Thank you for taking the time to complete this.